from happening. With that being said, here the follow-up 19 months of the cohort as of this summer. We have a survival at 2 years of 89%. Patients are maturing nicely. We had 9 events. Of those 9 events, we had 4 CNS relapses. Of the 4 CNS relapses, 3 of them happened in patient with a white count above 75,000. Therefore, is 15 intrathecal chemotherapy good enough? I think it's hard to walk away from chemotherapy for somebody with a high white count. I think we may need to still give some systemic chemotherapy for this patient. This is a work in progress. So, I'm sorry. So, and then I'd like to highlight as well, among these 62 patients, only 1 patient received transplantation. And these patients are being monitored by NGS and RT-PCR for MRD. Other drugs, olverembatinib is a very potent BCR-ABL inhibitor. At the ASH meeting will be several presentations on this drug from China, active in CML. In this cohort from last year, 10 patients with T315I mutation, 6 of them were MRD positive. Of the 6, 4 responded, achieved a CMR again, and of those with relapsed disease, 3 of the 4 responded. There'll be a presentation this year on olverembatinib at ASH as well. My colleagues from Dana-Farber did assess a combination of dasatinib, steroid, and asciminib for 3 months, and then they go for transplant thereafter from there. They established a recommended phase 2 dose of 80 milligram of asciminib. They will show this data at ASH this year. That's why I could not disclose the information and show it to you here. You have to wait for ASH. And then what they're moving in a phase 2 study is adding blinatumomab to this regimen. They give first triplet at the beginning, and from months 2 and onward, they give a blinatumomab. They still rely for transplantation in their practice, and they give 8 intrathecal chemotherapy to 12. I think we need more CNS prophylaxis. That being said, before I conclude, a word on monitoring. What we did, we compared MRD by NGS to MRD by RT-PCR. What we've seen is that NGS has a better capability of differentiating for the outcome. In fact, this concordance rate in the middle is 32%, and 20% are NGS negative of the PCR positive, which is reassuring. In contrast, those who are NGS positive are 12%. These are refractory patients, therefore. You see on a slide here as well, the blue curve, NGS MRD negativity. And on the right side, my right side is, as long as you're NGS negative, whether you're PCR positive or negative, the outcome is identical. Therefore, if you want to make a decision to go for transplant based on MRD, this should not be based solely on a PCR. You should consider NGS for immunoglobulin receptor. Something is being done in Europe for a long time, not so in the USA. Our research algorithm at MD Anderson today is the following. Ponatinib blina upfront for everybody, unless we have evidence of CML lymphoblast phase, and usually we check the P210 transcript, we fish the myeloid cells. If they have evidence of myeloid disease, we go for more chemotherapy approach and transplant. Otherwise, blina and ponatinib, assessed for MRD at 3 months by NGS and PCR. If NGS is MRD negative, fine, maintain TKI. Otherwise, if NGS MRD positive, we have a protocol today using CAR T cells for MRD positive patients. Assess post-CAR T for NGS MRD. If it's negative, maintain TKI, otherwise go for transplantation. Again, our decision to go for transplant is mainly guided by NGS MRD. In conclusion, can we walk away from transplant? The answer, in most patients, yes. The decision should be based on MRD assessment, and mainly in patients who do not have ECARS lesion plus. I think today, ponatinib is the best TKI available to us today, based on randomized trial. Do we need intrathecal chemotherapy or systemic? I think intrathecal 15, yes, but some patients may need still systemic chemotherapy, mainly high white count. Blina ponatinib or blina TKI is really standard of care, should be on standard of care for the majority of the patient. P210, CML, blast phase, chemotherapy and transplant is still needed. New drugs, Dr. Fawa highlighted, subcu blina, very exciting data. You will hear more about at ASH this year. It's really going to be practice changing. And finally, can we do in ALL what we did in CML and use a treatment for remission, maybe dictated by the kinetic of response and depth of the response remain to be seen. And as Dr. Fawa highlighted in his last slide, this is MD Anderson evolution from 10% survival to 90%. It's really a success story. With that, thank you so much for your attention. And the next speaker is Dr. Gökbuget. We'll go over the T-cell ALL. Nicola, the floor is yours.
Yeah, good afternoon. Thank you for the kind invitation to this meeting at this wonderful location. It's my pleasure now to speak about TALL, where many colleagues often complain that we don't have targeted therapies and no new drugs. But still, I think there are some good news to report also for this type of disease. So these are my disclosures. First of all, I would like to highlight that in TALL we have some specific clinical problems. Often patients have a large amount of tumor load and high risk of tumor lysis. In this context, also risk of, for example, thrombosis, which may happen due to compression in the mediastinum. Sometimes in the good risk subtypes, we have a very rapid clearance of lymphoblasts, and we have already cases seen where over the weekend no blasts were available anymore in the bone marrow. There are emergency situations due to large tumors in the mediastinum. We have issues with a higher risk of CNS relapse, and we have specific issues also with remission control because we need different imaging procedures, and most of them are not really validated for the remission control in TALL. Now, what about diagnosis? Also, there are many open questions. Particularly, there is no uniform classification of TALL. There's an EGL classification. In the German group, we did for historic reasons a specific classification with only 3 subtypes. I will come to that. Then there is the classification reported, for example, by WHO and the International Consensus Group, the differentiation between ETP, near ETP, no ETP, and in the GRAL group, for example, in the French group, there is in addition a molecular classification, which is associated also with risk stratification. So this is quite confusing also, particularly if we want to compare results on an international level. And due to our own databases, I will focus, we're showing results on the GMAL classification, which stratifies the TALL into early, thymic, and mature TALL. And the early TALL also includes ETP, but also non-ETP immature cases. And in our hands, the early and the mature TALL are high-risk groups, and the thymic TALL is standard risk. And when we speak about risk stratification in TALL, there are different approaches, so there is no uniformity. For example, in the French group, there is a stratification by notch mutations and the lack of RAS-P10 aberrations. In this case, patients are low risk. On the other hand, patients not having notch but being RAS-P10 positive, they are high risk. And this is demonstrated below on the survival curves with a quite relevant number of patients, but this classification has not been used to my knowledge by other groups so far. And the MD Anderson have reported results for the immunologic subtypes with the poorer results for immature TALL, as you can see here. And in the German groups, as said before, we have observed rather poor results, particularly for the early subtype of TALL, but also for the mature TALL, and better results for the thymic subtype. These are data from not from the recent study, but from a prior trial. Now, if you look into the clinical outcomes of TALL, you can see that results are overall quite favorable if pediatric-based regimens are used. But there are various age groups in these trials, different types of risk stratifications and transplant indication, and often the patient numbers are quite small. In order to look into the results from a larger data set with a modern pediatric-based regimen, I would like to show you now some results from the GMAL trial 08. We have completed this trial last year with more than 1,000 patients recruited over 6 years. And this is a pediatric-based regimen with a 2-phase induction therapy, a reinduction therapy, and several cycles of methotrexate and asparaginase. As indicated by the stars here, this is a very PEG asparaginase heavy treatment given for patients at the age of 18 to 55. We have in this protocol a risk stratification, so patients with high-risk subtypes, early and mature TALR, are candidates for a stem cell transplantation after the first consolidation, and all patients remaining MRD positive were candidates for one cycle of nelarabine in order to reduce the MRD load. And in the standard risk patients, we also added nelarabine cyclophosphamide to this backbone. These are the patient characteristics, and I think there are some differences to be highlighted between the different subtypes of TALL. Particularly the early TALL is a subtype where you have a significantly lower proportion of patients having a mediastinal tumor. So this is one clinical difference, and also patients tend to have lower white blood cell count. This also leads to my personal opinion that the white blood cell count has no role as a prognostic factor in TALL. We have validated this several times, but some groups still use the high white blood cell count above 100,000 as a high-risk feature. Now, looking at the CR rates in this protocol, we see overall a CR rate of 84%, which is a little bit lower in lymphoblastic lymphoma. This is due to the fact that a number of patients just have a persistent mediastinal tumor, and this, if you do a PET-CT, most of these cases are PET negative. On the other hand, we can see that patients with early TALL even have good hematologic CR rates than the other groups. The question is now, does this hold true if you look on the molecular level? And there is one additional problem in early TALL. We have a quite high proportion of patients where we have no molecular MRD marker based on clonal immunoglobulin and T-cell receptor rearrangements. This is 1/3 of the patients, and this is really a problem because we urgently need MRD in these patients, and therefore we try to establish in these cases now a flow cytometric assay for MRD testing. Looking at the MRD results, we find overall 70% molecular CR, but a significantly lower proportion of molecular remissions in early TALL. And this is, of course, the basis also for the poor results of these patients. Now, looking at the course of MRD during the induction therapy, we find a relatively high amount of patients with thymic TALL already in molecular CR after first part of induction. All the other groups have a low remission rate at this time point, but this increases through the induction phase 2. We have additional drugs like cyclophosphamide, RRC, and MP significantly. So this initial phase of treatment is very important to increase the molecular remission in these patients. And in induction phase 2, of course, you have the effect also of PEG asparaginase, which is given at the end of induction 1 and works throughout the induction phase 2. So the whole initial treatment leads to an increase of the molecular remissions, particularly in thymic TALL, to a lesser amount in the other subtypes. Now, if we look now into the use of nelarabine in the standard risk patients, we have added these 2 cycles after reinduction therapy. And overall, 103 patients were treated with nelarabine in this setting. And I must say the tolerability of this cycle, if you look here at cytopenia, for example, lymphopenia, is very good. So it induces much lesser risk of severe cytopenias, infections than other cycles given in this situation. Of course, there are some specific issues like the CBK increase up to myolysis. This is observed in some of the patients. And we had one case, and this is the most feared complication of nelarabine, is the ascending Guillain-Barré syndrome. It's one patient, but fortunately this was reversible. Now, on the other hand, we have used nelarabine to reduce leukemia burden in patients who remained MRD positive. And this didn't work. So in most of these cases, we had early TALL. These were only 14 cases. And the molecular CR by nelarabine was only induced in 1 of these patients. So this compound does not appear to be effective in these patients. Now, looking at the outcome, we have an overall survival in TALL of 78% at 3 years. So this looks quite favorable. That's 281 patients. And for T lymphoblastic lymphoma, the results are even a little bit better. Regarding remission duration, we have 88%, and there is no difference between ALL and lymphoblastic lymphoma. And I would like to highlight here also the pattern of relapses. In this protocol, we had 0 CNS relapses, and this is, of course, probably due to the heavy methotrexate, but we have also still CNS irradiation in the protocol and a high number of interthecal applications. We have improved the results of early and mature T-ALL here. We are now at around up to 70% survival, and the survival in thymic T-ALL is excellent. So this is really a very good subtype, and this is even more evident if you look by age. So the younger patients do still better than the older patients, but also in older patients, we have a quite favorable outcome with this protocol. Now, looking at the age group only in thymic T-ALL, you can see that age has no impact, so every age group has a good outcome, but there's a big difference in early T-ALL. And I have to mention here that we transplanted all the patients, so nearly 80% of these patients received an allotransplant, and here, of course, the risk of the patients older than 35 years lies also in the transplant-associated mortality. But on the other hand, the patient would probably do not have a good outcome if not transplanted as well. Now, overall, the transplant results are shown here. In all high-risk T-ALL cases, the overall survival is 68% with 15% transplant-related mortality. And in the early T-ALL, the transplant-related mortality is even higher, which may be due to the fact that the patients are, by average, also older. Now, looking overall at the older patients, we have used a protocol. We have shown that at the ASH 2022 for older patients, modified without asparaginase induction, but only during consolidation. And here in the most recent version of the protocol for T-ALL, we have achieved in patients older than 55 years a median survival of 59%. And looking into the different age groups, in this version of the protocol, patients aged 56 to 65 years have also really a very good outcome, and this underlines that this protocol can be a standard for older patients, whereas in those above 66 years, still there is much room for improvement. This curve is much more depressing and shows you the results of relapsed T-ALL. Over the decades, no improvement. And this is, of course, due to the fact that we have no good management approaches for relapsed T-ALL, particularly if you use nelarabine in the first line. So what are the important elements of the treatment in T-ALL? The dexamethasone, I think, in induction was one part which was important in our protocol, intensive asparaginase, and optimal CNS prophylaxis, the high-dose methotrexate, and there are still discussions which type of methotrexate, 24-hour infusions, or Carpisi, which dose. And what becomes evident is it's an essential need that we need more and better options for the treatment of relapsed refractory T-ALL. Moving forward, is one approach is nelarabine. I have mentioned we didn't analyze so far the impact of nelarabine in our protocol, but that there are pediatric data showing that nelarabine can have an impact on improving outcome. And the next compound where improved outcome has been shown was bortezomib, where the improvement was particularly observed in pediatric patients with T lymphoblastic lymphoma. The MD Anderson has used a different approach. This is a summary of different modifications of the hypercVET backbone. And so far, the best results have been obtained with a combination of nelarabine and asparaginase. There was also a cohort where venetoclax was added to the backbone, and I'm still not sure whether this really works. So I think we will discuss that later. So there are nice pictures which compounds could be used in T-ALL. This is one of them. A long list of potential drugs, but we have no really relevant data on that and no availability also, particularly if we speak about CAR T cells for T-ALL, for example. So our focus is currently to test venetoclax in the immature T-ALL and also CD38 antibody. So to summarize, we have a very good outcome in thymic T-ALL. It's easy to identify just by CD1A. We have early TALL, our focus, where we still have significant problems. The outcome is improved by transplantation, but still not as satisfactory. Nelarabine is integrated into the first line in the meantime, but we need to further define the role of nelarabine. Bortezomib will be maybe the next step to introduce into the first line in TALL. We have still issues with diagnostic characterization, prognostic models, they vary, and we need to evaluate new compounds. And in the European collaboration, there's also a discussion whether we could integrate in vitro testing into the selection of new drugs. And by this, I would like to thank you for the attention and also thank all the colleagues from the German ALL study group.
We'll take questions at the end during the discussion, and the last speaker of today, my friend Dr. Chaganti, who will go over cellular therapy and transplant consideration in ALL. Sridhar, the floor is yours.
Thanks for the introduction, Elias, and thank you for inviting me to speak at this session today. I'm Sridhar Chaganti. I work at University Hospital Birmingham and the University of Birmingham, and I'm part of the UK NCRI ALL group. The three speakers before me have made my task a bit easier today. I'll focus on the role of CAR T therapy and transplant. Parts of it is already covered by the previous speakers. And there will be a bit of focus of the practice in UK and my own practice at the University Hospital Birmingham. So I guess you will all know that we have two approved products for CAR T therapy in relapsed refractory B-cell ALL, which is Kymriah or Tisa-cel for patients up to the age of 25, and Tecartus or Brexu-cel for patients 25, 26 and above. In the UK, we have a national panel for pediatric ALL and for adult ALL to approve treatment for these patients. And this is the approach that we take in the UK. The treatment is currently approved for patients with primary refractory BALL, defined as being not achieving CR after induction and consolidation chemotherapy, or secondary refractory ALL, where there is no CR achieved after at least one cycle of salvage treatment, or relapsed BALL with relapse occurring with the CR1 of less than 12 months, even at a first marrow relapse. Otherwise, standard indication is second or greater marrow relapse for BALL with or without EMD, any relapse post-BMT, but there needs to be a bit of washout after BMT. And in the UK, we also allow patients in first relapse if they are otherwise deemed to be unsuitable for BMT for whatever reason, especially in the pediatric indication, and also Philadelphia positive ALL in the relapsed refractory setting in a similar kind of way, but typically they should have experienced 2 TKIs or at least 1 second generation TKI. The approval of Tisa-cel was based upon the pivotal study Eliana, which is now published over 5 years ago. 92 patients enrolled into this phase 2 single-arm study, 75 patients infused, and fairly refractory patient population, as you can see on the slide. And the initial publication showed a event-free survival of 50% and overall survival of 76% at the 12-month time point. So we have updated results with a 3-year update from the Eliana trial. And on the left panel, you will see the duration of response for all patients who achieved CR or CRI, that is 66 patients, and their 3-year duration of response is just over 50%. So roughly half of the responding patients have managed to retain the response at a 3-year follow-up. And on the right side, you see event-free survival for all infused patients, and that's running around 45% at the 3-year time point. And the survival curves do seem to flatten out, so the treatment appears to be curative in the pediatric setting. There was also some data on B-cell recovery in this update. So if you look at the blue line, with the bottom line, the blue line, which is B-cells recovering within 6 months of CAR T infusion, 10 patients on that curve, their median EFS was only 12 months. And if you look at the orange line, which is patients in a sustained B-cell aplasia, their median survival EFS was over 27 months. So it's a big difference between patients who have sustained B-cell aplasia versus patients who have an early B-cell recovery within 6 months. The top green line is patients whose B-cell counts recovered after 12 months. There are only 4 patients on that curve, and they seem to be doing fine. So early B-cell recovery seems to impact the event-free survival in this patient group. So this is data from our UK national panel. This was presented in ASH last year, currently manuscript in preparation. So 142 eligible patients, of whom 117 were infused, 101 patients were in CR, and 51 patients are alive in ongoing CR. 50 patients had an event, as you'll see on the consort diagram. 11 had frank relapse, 17 had MRD relapse, and another 17 had loss of B-cell aplasia, all of whom received subsequent therapies as outlined there. So at a median follow-up of 16 months, just over half of the patients who had an event were managed to be salvaged. But as you see, the success of salvage really depends upon what event it is. So loss of B-cell aplasia, 12 out of 17 patients were salvaged successfully. With MRD relapse, 9 out of 17 were salvaged, but with a frank relapse, the salvage rate is really low. So if you're trying to intervene, you should try and intervene for loss of B-cell aplasia or MRD relapse as opposed to waiting for a frank relapse. And on the right panel, you see the overall survival of 65% at 2 years, and the classic event-free survival as defined in Eliana of just around 45% at 2 years. And we also defined something called a stringent EFS. So this takes into account also loss of B-cell aplasia and MRD relapses. So stringent EFS was only around 35% at 2 years in this cohort. So progress, but there is still a significant unmet need even in the pediatric setting. When you look in the adult setting, so this is data from Tecartus or Brexucel. This is a 2-year update from the ZUMA-3 study. And you'll see in the top panel that is relapse-free survival, patients were censored for subsequent allogeneic stem cell transplant on these curves. So the green line is patients who were in CR or CRI. 39 of the 55 patients achieved CR or CRI, and their median relapse-free survival is running just over 15 months. And patients, the blue line is all treated patients for whom the median relapse-free survival is just under 12 months. So the bottom panel shows survival. This is overall survival for all infused patients. And that is median overall survival running just over 2 years, with small difference between CR, CRI, and all infused patients. Clearly, those patients who did not achieve a response did extremely poorly. So moving on to the role of transplant. So I'm summarizing my thoughts. Transplant is a kind of moving field in the treatment of ALL. So if you just look at CR1 allografts, currently, if disease status, if standard risk cytogenetics, I think it's agreed that there is no need for transplant unless there is a MRD persistence for these patients. Patients with high risk cytogenetics, do they need a transplant? If they become MRD negative, the benefit is uncertain. And also I'll show you some data which shows that if you transplant for patients with higher risk cytogenetics, then their outcomes are inferior compared to patients with standard risk or good risk cytogenetics. Philadelphia positive ALL, Elias has already shown very nicely. The role has been evolving. Traditionally, everybody was considered for a transplant. The benefit is uncertain if CMR is 3 months, as patient is in CMR by 3 months, especially if they are treated with ponatinib-based regimens. MRD risk, if you have MRD persistence after consolidation, then that's a classic indication for transplant. That's a main indication for transplant in this day and age, I would say. But if you're MRD persistent going into transplant, your transplant outcomes are inferior. So you should try and make your patient MRD negative. MRD positive out of quantifiable range, so that's very low levels of MRD, which are less than 0.01% type MRD. And there, the benefit is a little bit uncertain, and again, I'll show you some data. And MRD monitoring may be preferred in this in this patient group. If you eradicate MRD with blinatumomab, do you still need transplant, or can you observe these patients? And that is, I guess, the risk-benefit needs to be assessed. And again, I'll show you some data from the BLAST study. And here we're talking of allogeneic stem cell transplant, TBI-based MAC for young patients. who are fit for a MAC regimen or RIC transplant for patients over the age of 40 to 45. So taking the first question, should transplant consolidation be offered to high-risk ALL patients in CR1 if they are in a good response? And we have, there are multiple data, but I'll show you this one. This was a French GRAL study published a few years ago now, where over 500 patients who were deemed to be high risk, either because of cytogenetics or baseline characteristics, were allocated either to transplant or non-transplant. Around 280 patients were transplanted, 240 patients were not transplanted. And as you'll see on the figures on the right side, the top figure is relapse-free survival and the bottom figure is overall survival. So the dotted lines are patients who were in a MRD negative response, and that MRD was less than 10 to the minus 3. So there was no benefit to transplant in patients who were in a MRD negative response. Patients who were MRD positive clearly the solid gray line is patients who had a transplant, and the solid black line is patients who did not have a transplant. So if you're MRD positive, then there is an indication for transplant, and that does improve both your RFS and overall survival. This is a large CIBMTR analysis of over 1,700 patients looking at leukemia-free survival after allogeneic stem cell transplant, specifically in patients with high-risk cytogenetics. And on the left panel is analysis based upon the modified MRC ECOG cytogenetic risk stratification. Again, you'll see the patients who are doing well is the patients with standard risk cytogenetics, that is high hyperdiploidy. That's a tiny number. Only 24 of the 1,700 really are on that plot. And the bottom curve is patients with very high-risk cytogenetics, which is T411, T814, complex karyotype or low hyperdiploidy, or high-risk cytogenetics, which is 11q abnormalities, monosomy 7s, or deletion 7p. So their outcomes are inferior. In the CABMT analysis, they also proposed a new cytogenetic stratification for patients post-allograft, which is shown on the right side. So again, patients who have adverse cytogenetics such as monosomy 7 or complex karyotype, deletion 7q, translocation 1119, their outcomes after transplant are significantly inferior to outcomes for other patients. Having said that, if you're looking at maybe around 35-40% survival in these patients, that may still be better than what they have without a transplant. But if they become MRD negative, will they still benefit from transplant? That is, I guess, the uncertain element in this. Multivariate analysis from the same CIBMTR analysis, looking for impact of conditioning regimen, remission status, and cytogenetic markers. So patients who had a MAC without TBI or RIC allograft did worse than patients who had a TBI conditioned MAC transplant. Patients who had a transplant in CR2 had worse outcomes than patients in CR1. And again, the impact of cytogenetics, as we discussed, the complex karyotype, monosomy 7, they had a significantly worse leukemia-free survival, even on multivariate analysis. So this is data from UKLL 14 trial. And if you just concentrate on the red and green lines, the top panel is the overall survival and the bottom panel is the relapse risk. So the red line is what is called the very high-risk cytogenetics, which is complex karyotype and low hypodiploidy. The green line is patients with KMT2A fusions. So all these patients were allocated to a transplant in the UKLL 14 trial. So this is intent to treat transplant analysis, if you like. And as you see, their outcomes are really poor, even with an intent to transplant in this patient group. So should transplant consolidation be offered to patients with persistent MRD after induction and consolidation? I've already shown you the GRAL data, which suggests that transplantation is beneficial for patients who have persistent MRD. I'll show you some data from UKLL 14 trial. So this is published now. This is data from the RIC allografts in the UKLL 14. There are around 200 plus patients on these curves. And as you will see, on the left panel, it is patients' relapse-free survival, and on the right panel is overall survival. Both are impacted by MRD persistence. So patients who were MRD negative or positive but outside the quantifiable range had much better RFS and OS compared to patients who were MRD positive going into the transplant. So these days we routinely offer blinatumomab for MRD eradication prior to the transplant. But if you do successfully eradicate MRD, as happens in a majority of patients, should we still be transplanting these patients? And Nicola, who is talked before me, has published this data. This is outcome from the BLAST study. For those of you who do not know, BLAST was a phase 2 single-arm study for MRD eradication in BALL. And as you will see here in this figure, for patients with relapsed ALL, the orange bars are patients who did not have a transplant consolidation after achieving MRD response. Green bars are patients who had a transplant consolidation after achieving MRD response. So if you look at patients who did not have a transplant consolidation, their relapse risk was particularly high. 60% of patients relapsed even after achieving MRD response. So transplant does protect patients from relapse. But part of it is compensated by the TRM related to the transplant, as you will see in the middle plots. And overall, more patients were alive if they had a transplant consolidation than if they did not have a transplant consolidation. And the survival curves in panel C and D show you the impact of transplantation. So panel C is patients who had a transplant consolidation after achieving MRD response. That's the blue line. And on the bottom line is patients who did not have a transplant consolidation. And even patients who did not have a transplant consolidation, they do seem to have a median survival going on to something like 50 months if they are in a MRD negative response. So there is a proportion of patients who may have durable MRD, who may have a durable remission without a transplant consolidation. Should transplant be offered to Philadelphia positive ALL? I think this is already covered by Elias, so I can keep this very, very brief. Elias has already shown updated data from this as well. And this was published a few years ago now. This was MD Anderson single center hyper-CVAD plus TKI, a range of different TKIs given. The analysis excluded patients who had an allogeneic stem cell transplant. And if you just look on the right panels, panel B and D, these are patients who were in a CMR at 3-month time point, and their median relapse-free survival running around 120 months and median overall survival running around 120 months. So these patients have done really well. And Elias has already shown some data that ponatinib seems to be more effective than dasatinib or imatinib in preventing relapses without a transplant consolidation. So moving on to relapsed refractory ALL. So the indications for transplant for patients in CR2, I would say it's standard of care in this day and age. Probably not required for patients in children and young adults who have a low-risk relapse. In the UK, we don't routinely transplant them. And increasingly post-CAR T, the issue of transplant consolidation has been a topic of discussion. Should we offer it to all patients? Probably not. The role is uncertain. It appears to reduce the risk of relapse, but comes with a significant treatment-related mortality. If there is MRD persistence or recurrence after CAR T therapy, then I would say transplant should certainly be considered. And for early loss of B-cell aplasia, especially for Kymria patients, our practice is to consider a transplant consolidation, but for patients treated with Tecartus or Brexucel, this remains unknown. So if you just look at patients who achieve CR2 after blinatumomab or inotuzumab treatments, so unlike for blinatumomab for MRD eradication, there clearly is a clear benefit here if you transplant after blinatumomab for relapse setting. This is the data Elias published a few years ago now. If you look at the blue lines, the solid blue line is patients who had blinatumomab for relapsed refractory BALL and had a transplant consolidation, and the dotted blue line is patients who had blinatumomab but did not have a transplant consolidation, and there is a big difference in their survival, 50% versus 25% if you do not have a transplant consolidation. So clearly transplant is beneficial for relapsed refractory BALL in CR2 if they respond to blinatumomab. And this is data with inotuzumab, InnoVate study, again a phase 3 study of inotuzumab versus standard of care. And 71 patients had a transplant after inotuzumab, 50 patients did not have a transplant after inotuzumab, and there is a clear survival difference between those who had and those who did not have a transplant. And lastly, about transplant consolidation following CAR T therapy. So this is recent data published on patients following Brexucel in the ZUMA-3 study. This data combines both phase 1 and phase 2 cohorts. 14 patients went on to have an allogeneic stem cell transplant after having responded to Brexucel, and that's the purple line. And the panel A is duration of remission, and panel B is overall survival. So clearly, if they had a transplant consolidation, their median survival was better. Median duration of response was better, of around 44 months. Those who did not have a transplant consolidation had a median duration of remission of only about 18 months. But there was no difference in overall survival for these patients. So I guess whether you routinely consolidate with allogeneic stem cell transplant remains an open question at this point in time. So those are my thoughts for the current role of cell therapy in ALL. I guess CAR T therapy indications are pretty straightforward. For eligible patients, it is current standard of care. And the role of allogeneic stem cell transplant is evolving to be considered for all patients in CR1 if they have MRD persistence after consolidation, but try and eradicate MRD with blinatumomab prior to the transplant. To be considered for patients in CR1 with adverse risk cytogenetics, but if they become MRD negative, then is it really indicated is a unknown entity? In CR2, for all patients other than low-risk patients with childhood and young adult ALL, for MRD persistence post-Kymriah and Tecartus certainly, and to be considered for early loss of B-cell aplasia with Kymriah. With that, I will end my talk. Thank you.
So I want to start with a question to Nicola. You look at neurabine data in ETPLL or early T cell, it doesn't help, correct? So today, in the setting of we have a randomized trial from pediatric at MD Anderson, for ETPLL, neurabine doesn't help at all. It only helps in the timing and the mature, but not in the others. So my question to you is for the early T cell ALL who are MRD positive, what do we do?
Work? Yeah. Yeah, we tested nelarabine, as I have mentioned, and it doesn't work. And there are some discussions that in ETP-ALL we should use AML-like therapies. But what is that? My question is, we have every drug in the backbone of ALL management, which could be AML-like regimen. So I think we can consider in these patients venetoclax. We will try that, and also probably CD38 antibody in the MRD setting. There are some data in full relapse, but in the MRD setting, maybe these compounds would work better. For venetoclax, I'm worried to, maybe you know more about that, to combine it with chemo because it can lead to high rates of cytopenia. So I would do it in a lower dose, maybe at a lower leukemia burden.
So when we modified the last version of the Hyper-CVAD, we had venetoclax as we do in AML, but we had myelosuppression in grade 5 and infections. So right now we do only 5 days during induction therapy with Hyper-CVAD, and only for ETP-ALL and MRD positive, we do 3 days in the second course. If they go into MRD negativity, we abandon ven because the risk of myelosuppression is quite high.
And therefore, I think it's not such a big problem if the patients go anyway to a transplant, and therefore I would do it in a later stage, because we still have problems with mortality and induction also in the ETP cases, mortality in CR. So they have a combination of many different problems, unfortunately.
Okay. Any comment? Before we comment on T-cell? Go ahead.
Yes. 2 questions, actually. The first one for Dr. Foa. if you have a patient right now, an older patient, and you had access to medications and based on the current clinical data, would you give blinatumomab with dasatinib or would you give blinatumomab with ponatinib as a frontline treatment? If you have access to medications and no insurance issues.
Now, the easy answer would be I don't know.
Okay.
You have to extrapolate a little bit. You can't just. No, I mean, no head-to-head data. So, I mean, this is something we always discuss. I mean, we've done imatinib, dasatinib, now we're giving ponatinib. Now, in theory, ponatinib is more effective. However, two issues. I mean, it is more toxic than dasatinib. I mean, our trials these trials have no upper age limit. So we have to consider the over 60, 70, 80. So I don't know, we'll have to see. The other point is that dasatinib does modulate the host immune system. This we saw many years ago in CML, in fact. Dasatinib per se. When we did the dasatinib-blina study, we monitored, and to our surprise, we saw that at the blina there was a progressive modulation of the immune system, increase in T cells and K cells. The Tregs didn't go up, so that was all good news. Now, will we see that also with ponatinib and blina? I have some preliminary data, but I don't know. It could be that you have less immune modulation. So, if we have to balance, we're probably going to have less relapses because obviously with dasatinib you see more mutation. The 315 is evident in 9 relapsed in the ALBA, 7 had the T315. So you're going to probably, from that point of view, it's better. But we'll have to see. So it might be better in the long run, but we'll have to see if the toxicity is in fact in the elderly, and if the immune system is less modulated, if that pays a. So there's no, that would go back to my first answer because I don't know.
But there's no randomized trial, right?
No, there's no trial.
So we are going to be stuck with the...
we are randomizing the first one ever, but it's with imatinib, for the reason I think you mentioned it, that imatinib is approved worldwide frontline. Dasatinib is not. It's approved in a couple of countries or so, or maybe a bit better now, but when we designed it, that was 2 or 3 years ago, the obvious comparator had to be imatinib. So there's no head-to-head.
And my second question is for Eli, actually. So the study that you saw for Marlis-Lux, I wasn't sure I understood the design. So it has both asciminib and dasatinib?
Correct. They combine, asciminib is allosteric inhibitor of the BCR-ABL, different binding and different reputation profile. And they combine with dasatinib 140 milligram per day. They give the combination together daily. And they give steroid for a month's full dose, and they taper over 2 next months till day 85. And then they go for transplant or no transplant based on
So you think this would be the approach of the future, like 2 TKIs?
This is their approach. It's not my approach. Okay. I don't like to combine TKIs.
That, if I may, let's be very open. Do we have data with asciminib in Philadelphia positive ALL, strong data?
No.
Exactly, I don't. We tried it, and when the CML study was ongoing, you could also enroll Philadelphia positive ALL relapse. We did a couple, and we saw no response.
Okay, well, then the CM...
Very advanced disease, obviously.
I cannot disclose the information because I'm aware of it, and ASH is coming.
Nobody's hearing, so you
the CMR rate is not higher than what we see with single-agent TKI.
Yeah, and the last question I have, if I may, regarding the T-cell talk. So, this issue of IT prophylaxis, and I know it's, emphasized all the time, but do we really know for sure that we are helping patients with IT prophylaxis? I mean, it seems every large study in lymphoma, the last one I'm sure you saw in JCO, all of them are negative. So do you think because we have circulating cells that we are actually definitely helping patients based on the pediatric literature with IT prophylaxis for patients, even with the novel agents?
So I'm not so sure whether the ET prophylaxis was really sufficient, particularly in TALL. We do a lot of intrathecal injections also during the whole consolidation and maintenance, and it's always questionable what this really whether this is really so important. So my feeling, also from all the GMAL trials, is that you have to do a lot of CNS active compounds in TALL in the beginning. Yeah? And there are limitations, of course, for intrathecal prophylaxis in the beginning because it adds also toxicity to the backbone. And also, I'm not convinced that we can get rid of methotrexate as systemic therapy. Maybe you have shown that for the pH-positive ALL, but I have no good feeling about that because we have a lot of extramedullary involvement also in TALL, not only CNS, other locations. And therefore, I believe currently we cannot get rid of the CNS irradiation in TALL. Maybe we can reduce it, but not get totally rid of it.
Even with the mini CVD, where we reduce the methotrexate dose, we worry about CNS disease relapses, and we have 6%. So we implement 12 intrathecal methotrexate instead of 8 traditionally we do with the hyper-CVAD. So no, we cannot omit it. And then second observation, when we did systemic methotrexate, the 1 gram meter square given over 24 hours, and we give methotrexate intrathecal at the same time, and we have somebody with renal dysfunction, we had a major toxicities from methotrexate. And therefore, we decided to space out. So when we do the methotrexate systematically, we move the RSC early on and methotrexate for later on to avoid this myelopathy and complications.
And maybe one comment also, we will show at the ASH a randomized trial where we try to omit the CNS irradiation in B precursor ALL. And there were really surprising results that the patients without CNS irradiation had more systemic relapses. So it is not an easy question, and because particularly if you have a disease where you have no real effective treatment for relapse.
My last question for Dr. Fawad. Do you feel like big asparaginase is a drug we struggle with? I've seen all kinds of sinus thrombosis and horrible side effects, and we cannot wait to get rid of it. And I saw I didn't realize that even Europe, they are kind of moving away, like with the TKI for Philadelphia positive. So do you feel comfortable at this point to remove big asparaginase in, let's say, someone who's 55-year-old with ALL?
Well, we haven't removed it yet. I mean, we removed it in the pH-like study. You saw that, yeah, there we decided to remove it, but we added ponatinib. And the other, it's still there. It is clear that the aim would be if the Blina data hold true. I mean, and the data we got so far is with one Blina, really. So if we go back to the Philadelphia, it's many Blinas. In fact, in our study, the primary endpoint was after 2, but we went up to 5 cycles of Blina, and we saw an increase in molecular response. So it could be that in a Philadelphia negative, Blina, more cycles of Blina could be even better. At that point, I imagine the next question, it's obvious, the next question is, can we reduce chemo? And therefore, I think asparaginase would be a candidate, possibly, although it's the single most active drug. I mean, we have to remember this. But as you said, clearly it has toxicity, particularly less young patients. So I think we'll probably go into that direction, having more Blina, I imagine.
So I have a question to Dr. Fawad, 2 questions. Number 1 question, you showed the data with the new GMIMA trial that the improvement was mainly in 55 years and younger. Well, up to 40, they do great. 50, but the 55 and older, they do not do as well. And the ECOG 1910 as well, those who are 55 years and older did not benefit as much from Blina. Any explanation?
Why do I always have to say I don't know? I mean, it's a second. We don't have any. Do you have an explanation?
No, but I assume that the regimen was too toxic in these patients because this was a regimen for patients 30 to 70 years with a strange age spectrum. And we don't know whether the relatively high mortality in CR was mainly in the older patients.
But again, I wonder if we gave more than one Blina, that could change. Because
more than 1 cycle of Blina.
Yes, okay. That was only one, and that was the final study, because the endpoint was to see the increase in the rate of MRD negativity. Since that is shown, then maybe we could give more Blina and reduce chemo, and maybe could affect the less young.
That's what we did in Houston. We reduced the chemotherapy by 50%, the hyper-CVAD, and we shortened the maintenance from 30 months to 12, but we had 4 Blina consolidation and 3 Blina in the maintenance. And then up to 60, we do not see 55 to 60, 50 to 60, they do well. The question is, can we move the low dose chemotherapy to the young population?
Yeah,
We're still not sure about it.
That's another question too.
And then the second question to you is the pH-like ALL. And I know you're not with ponatinib right now, but those who had a Blina and became MRD negative, do they have, the outcome is not as good, it seems, that those who don't have PH like ALL? Do we transplant them still?
Yes, we do. I mean, that's
But you do only one course for blina, so if you give more blina, will that change?
I can't
I do not know, of course.
Yeah, I can't answer that. It's obviously a question. We were surprised to see that they became negative and relapsed. So that's unexpected, and we're trying to understand more on that and studying other genetic markers, but maybe more. I don't know. Okay. One thing on the CNS, because this is coming up regularly. I mean, we are now in a protocol. We're giving 15 intrathecal as you're doing, and because we've seen more relapse in the Philadelphia positive. Now, if there are more relapses, or we discussed this a few days ago, or we've seen relapses because we've seen less hematological relapses, could be good news. But there is an issue of the CNS localization. So that, I think, is a very important point. And we started working on trying to identify genetic profile on primary ALL sample that could, I'm saying could, predisposed to a CNS localization. I'd like to know during the course of the disease, and we did publish a preliminary analysis that may be the case. We need to do this in a larger series. If that was confirmed, then it would go into the issue of tailoring, intensifying in some and reducing the CNS product in others. But that is for down the road.
I have a question regarding CAR T cells. So I thought, may I?
Yeah, of course.
Okay. You showed the data from real-world experience in UK, and it was a kind of intent to treat. I liked that a lot because this was exactly something which our payers, insurance people asked from us in Germany. So did you have a kind of upfront definition on whom to transplant or not to transplant in this setting, or do you have an impression what was the strategy of the physician?
You mean transplant after CAR T is what? So there is no upfront pre-planned transplant. Most of the patients who had transplant on our data set, on the UK data set, have been transplanted for an event after CAR T therapy. The upfront transplant was mainly from the Brexucell Zuma-3 data, where a proportion of patients have had a transplant once they achieved CR. With Kymriah in the UK, usually the practice is to monitor these patients, and transplant is offered at when an event happens to these patients.
Many of them pre-transplanted, so had a relapse after.
So there is a proportion of patients who had a prior transplant. If I remember it, something like 30-40% of patients had a prior transplant before they had the CAR T.
So can I comment too, or ask you something on the CAR T cells? So, because I mean, in the States, the policy is mainly CAR T and transplant, irrespective of the degree of response, opening an economic issue which is phenomenal. I mean, an allogeneic in the US is about $1 million. CAR T is about 500,000 if you don't end up in intensive care units, obviously. So if you have a good response to CAR T, you don't transplant, you monitor.
With Kymriah, certainly, yeah.
Yeah, okay.
Yeah.
The second question is, are you doing academic CAR T cells in the UK? Because the other big issue is who's paying for all this. I mean, I don't know what it's in Germany. I mean, we have a limited number of patients who can get the CAR T, not the limited number that we can do, put it that way. We or they, I mean, I'm luckily not directly responsible anymore, but there's a limited number because the region doesn't allow us to do more than X a year, only for cost reasons, which is obviously an enormous problem, this. And we don't do the academic. I mean, in Spain, as you probably know, they've done this big effort in Barcelona, and now they're going to EMA to get approval for that for the academic, which obviously will reduce the costs.
So there is no, the CAR T data that are presented is all commercial CAR T. It is funded by NHS England, National Health Service that is. And we do have these panels, the pediatric ALL panel, adult ALL panel. We have a panel for lymphoma, which has been set up primarily because of the cost reasons of the treatment, so that patients are kind of approved by the panel. Having said that, a majority of patients who come to a panel are approved by the panel, but there is if you're putting a patient to the panel, then you'll make sure that you work up the patient and you ensure yourself that the patient will meet the eligibility criteria. So I guess there is a pre-screening that clinicians do before they bring to the panel.
And it's a quick screening. I mean, you get a reply very quickly from the panel.
Oh, yeah, the panel meets...
That's another issue in some countries. You apply and they wait for another month. So then if you then got to mobilize and expand in an ALL, that's a disaster, obviously.
Yeah. So our panel meets weekly, pediatric may meet once every 2, but we can even get an approval on the email if required.
I want to answer the question of the CAR-T in PH-positive ALL. Of those 4 patients with CNS disease at MD Anderson, 2 of them, one of them had progressed and died, one of them had a transplant, and 2 patients had only CNS disease. NGS was barely positive or negative. So we give them systemic chemotherapy and intrathecal. We collect their cells, we give CAR-T, we do CSI and CAR-T, and we measure this CAR-T and the CSF, and it's positive. And so far, the remission has been 6 to 9 months, and we did not do transplant for this patient.
We didn't do that, but I must say that we had 4 CNS relapses and 3 are alive. So they respond to treatment probably with transplant. So you can, but if you can avoid the transplant,
correct.
That's the next.
But you do TBI for transplant? Do you radiate?
Well, depends.
Okay.
Depends on the center. So it's not a policy, not a unique policy.
So I have a question from the audience. In PH-positive ALL receiving CAR-T, would you consider maintenance with TKI after CAR-T?
We had a very similar patient, I have to say, somebody who's on ponatinib. It's an adult patient going for Brexucel CAR-T, and we had a lengthy discussion on our national CAR-T panel as to whether the patient should go back onto, he was on ponatinib patient, whether the patient should go back onto ponatinib routinely after CAR-T, because we still are not confident with the survival curves on Brexucel that it represents a cure for these patients. I guess there are yes and no is my answer, and to me it makes sense if you want to put them back on ponatinib, but there was some concern about is there an effect of TKI on the CAR-T itself? Dasatinib, for example, there is data. There are some case reports of using dasatinib for treatment of ICANS because it does alter your cytokine profile. So there is a little bit of concern about whether TKI...
But if you extrapolate from the blina dasatinib seems to modulate well the T cell system, and should not be a bad idea to put them on dasatinib.
It could be, definitely.
Okay.
You know, there were data in a preclinical setting published in Blood by a very good group suggesting that you should never give a TKI, particularly dasatinib with blina. In vitro, though. Correct. And it's slightly different in vivo. But
and in clinic, it does work so well.
Exactly.
I have a question for you,
Yes,
Elias, regarding the duration of TKI treatment. What is your impression on the long run? How is ponatinib tolerated?
We had ponatinib very well tolerated at the long run. And in fact, whenever we have low thresholds for any vascular thing, we take them off ponatinib, put them on other TKIs. But we have not seen major vascular events at 15 milligrams per day. We have the hypercivat ponatinib with more than 6 years of follow-up rate now, and seems to be well tolerated at 15 milligrams per day. Again, any low threshold for hypertension, any issues, we switch them to other TKIs to avoid any vascular events from happening. That being said, we have 10 patients who decided to stop TKI on their own because of intolerance issues or whatever. Of the 10 patients, we have 2 deaths from other reasons. We have 3 relapses. We have 4 relapses. One of them was back into blast phase disease, and 3 of them were like minimal disease, where we resumed the TKI back, and they responded. And 4 maintained the TKI. At parallel what we have in CML, where if you have a deep molecular remission for 5 years, the likelihood of relapse is really minimal. That being said, we're not at the stage right now to stop treatment on any of patients, but we're collecting data, Icarus deletion, depth of the response, NGS, kinetic, and try to figure it out if there's a certain group of patients whom we can stop maybe after 5 years or whatever, but that is not yet fully
Now, believe it or not, we have more patients than the MD Anderson who stop treatment.
The whole country.
No.
Yes.
I thought you were the whole country. No,
No, we have
not yet.
Only Houston.
Only Houston. Now, we collect the data from 14 patients in Italy who stopped with PH-positive, stopped treatment for various reasons, and 9 of these are still, more than 2 years later, still fine. The other 5 relapsed, but 3 re-challenged with TKI responded, like in CML. So this is a very open, I mean, it's amazing that we're talking about this. I mean, the fact that we're talking about stopping treatment in PH-positive is absolutely sensational. But this is it's a hot question. This, I mean,
How long?
it varied because it is not a study. This is a collection of individual patients. Correct. So they stopped for whatever reason. So it's obviously it's not decided. I mean, the longer the better, obviously. But this is it's not a study.
Okay. Any other questions from the audience? Nobody? We're coming to the end of the session then.
We managed.
Yes, we've on time, sharp on time. I want to thank Dr. Fo, Dr. Gökbuget, and Chaganti for being here today. I hope you enjoyed.